What I tend to see is that most of the design work around solutions in healthcare, in the US healthcare system, tend to be based around this concept of what I call the balanced interest paradigm. And the way the paradigm goes, it goes something like this: that if you want to create really great solutions in healthcare, those solutions have to address the needs of all the key interest constituents.
Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits to save lives, save dollars, and save your talent. Hey, welcome everyone back to Broken Benefits. Today, I am so excited to introduce our guest. It is Marcus Osborne. Marcus is, I've known him for a few years and have sort of thought of him as kind of an incredible leader and almost godfather to the employer side of the industry. Working with the world's largest retailer for over a decade, he helped to usher in some of the most important strategies that impact consumers and employees and families, really impacting over 100 million people with some of the first programs that include launching a $4 medication program, the first plus program ever, and also getting in preferred arrangements within Medicare Part D around drugs, as well as launching Walmart Health, an initiative to make care accessible and affordable and simple and logical. And so excited to have him here today to share his insights. With that, thanks for joining us today, Marcus, and welcome to the show.
Yeah, thanks for having me. You're one of
Absolutely.
my very favorites, so I'm excited about this conversation.
No, and I appreciate that. Hopping right into it, would love to get a little bit of a thought, from you on. You were working with an incredible array of tools and access to consumers. How is it that you approached the problem of fixing the problem of healthcare and trying to make solutions for it?
Yeah, it's actually, well, I think the biggest thing that I did, and the biggest thing I was really focused on um, I was very much focused exclusively on the consumer. And what I would say is what I saw as an industry, and I talk about this a lot, but I don't know that people kind of fully understand or sort of attempt to understand what I'm saying. But what I tend to see is that most of the design work around solutions in healthcare, in the US healthcare system, tend to be based around this concept of what I call the balanced interest paradigm. And the way the paradigm goes, it goes something like this: that if you want to create really great solutions in healthcare, those solutions have to address the needs of all the key interest constituents. So you have to address the needs of not just the patient, but the payer, the employer, or the health plan, or the carrier, or the government. You have to address the needs of the provider. That could be the individual physician, or it could be the health system. You have to address the needs of the product manufacturers, pharma, and the device guys. So if you want to create great solutions in healthcare, you have to address all the needs of all those constituents. You have to balance their interests, and when you do that, you will truly create solutions that work. That's wrong. What I've seen is the solutions that do that, they are overly complex. They don't like, and what you end up with, like, well, whose interest? What if interests conflict and those kind of, and what you
Yeah,
end up
you
finding,
can't
and
make
here's the
both of
great
them
irony.
happy.
Yeah, the great irony is when the better design approach is, how do I solve for consumer need? What is it that people need? How do I address their fundamental challenges as fully as I can, recognizing the constraints that the industry that brings? And the irony of that is, what I've seen is, not only does that end up better for the individual, but actually you tend to end up with solutions that the providers that engage in those kind of solutions are happier doing their jobs. You find the payers are happier because you have more engaged consumers and members. You find that the people are more adherent and tend to follow through. Pharma and are happier because you're seeing more here. So the irony is, the consumer-driven approach actually creates the best solutions for everybody. And so that's a lot of what I was kind of focused on. Is, even when I was engaging with employers and employer benefit groups, it was this through the lens of, how do I leverage Walmart and what Walmart is doing from in a health perspective? How do I bring these consumer design solutions to employers, but do it in a way that I don't you can't lose that mindset that this is fundamentally about solving for consumer member challenges first and foremost. Um, Recognizing that if you do that well, it's probably going to solve for the needs of the plan as well.
Hey everyone, now for a quick message from our sponsor.
Oh, I heard you got off social media.
Yeah, actually, it was just kind of depressing.
Did you know that 1 in 3 fundraisers on GoFundMe are for medical bills? And many of these people work for companies just like yours. Start giving your employees 100% medical coverage with Catalyze Health.
That makes completely logical sense. Why is it that more businesses don't engage the problem that way?
Um, well, because I think there are a couple of reasons. You think about providers and the health system side, and they'll say, yeah, but if the insurers are the ones who are paying for everything, I've got to figure out how to address their needs, because if I don't fully address their needs, it doesn't really matter if I serve people well. I'm not going to get paid. I think on the plan side, that what I will often say is, and I've seen this, the not all employers, not all benefit groups, but some benefit groups, is you start to believe your the needs of the business or whatever kind of outweigh the needs of the individuals, the members you're trying to serve. And so I think it's just sometimes hard. I mean, I think you get sort of distracted or just fundamentally believe that these kind of other constituents, that what they need kind of matters more, and it ends up sort of taking you down a path that you ultimately don't create solutions that work.
Wow.
It's just a mindset change, and also I think we've been designing that way in healthcare for so long.
Right.
I went 50 years, 60 years, that it's hard to kind of think about it differently.
How did you come up with the $4 program, and what were some of the obstacles you had to overcome to get it
Well, I look at the
into
team
market?
that did it. I mean, individual like Bill Simon, who eventually became Walmart US's CEO. The idea was a real simple one, which is, and by the way, it is kind of strange, that we're now looking at that was launched in 2006, and so we're not at quite at 20 years, but we're nearing 20 years ago that was launched.
Mm,
Um, if you look at I just saw a study recently that asked Americans, healthcare is still top concern, one of the top concerns, and you ask them what
100%.
issues in healthcare create the greatest angst and stress. Guess what's still surprisingly number one, at least on this study, was the cost of prescription drugs. So it's interesting that the same data point we saw that Walmart saw in 2005, 2004, 2006 was the cost of prescription drugs being a kind of issue. So the idea was just a simple one. Like, well, why can't we take these generics that are actually relatively cheap to manufacture, and if you
Right.
do it at scale, you get efficiencies, and identify really clinically appropriate therapeutics across every therapeutic category that is possible, and just
Right.
tell people, we're going to try to give them to you at $4 for a 30-day supply. Like, why, let's, and what happens, what's the kind of result of that? And I think what you looked at is the view, and I will tell you, this was something I kind of ran into often, that people would say, well, why would you sell it for $4 when if a PBM or some plan will pay you more for the same product? And aren't you just kind of leaving money on the table? And quite frankly, Walmart left money on the table. Many, well over, well, actually, there was a moment in time that just under half of Walmart's pharmacy transactions in third party were paid at usual and customary rates as opposed to contracted rates. So in other words, it was Walmart's cash price that prevailed, not the contracted rate that came through a PBM. So
Oh,
people would say, well, you're crazy. Why would you leave money on the table? Well, you leave if your desire is to serve the customer, then you say, we want to try to make things affordable. And it was based on a simple insight at that time that there are a huge, and it still is the case today, there are a huge number of people who have prescriptions that are either not filling them or are doing things like pill splitting or are
mm,
sharing pills between spouses or partners because they can't afford their meds. We still see it today, even with the advent of Medicare Part D and other things that enable people to better afford their meds. We still have that reality, and so I think it was just a simple idea of like let's make this more affordable and known and help people who are having to make tough decisions not have to make the tough decision. Like, no, you can afford your meds and afford food for your family too, or afford buy a birthday gift or a holiday gift for your grandkid.
right.
Like, yeah.
It's incredible. I saw a recent study on a church that got locked in an imbroglio of renewable energy that was outside the rules because they were trying to save money on energy. And in the interview, it was like, "How did you even get caught up in this? And why were you trying to do it?" And they said, "Well, because our members couldn't afford their medicine."
Yeah.
And so we went down this whole rabbit hole trying to save money in a totally different area that was sort of outside the rules. And it's like, couldn't we just find a way to reduce the cost of meds?
Help them save money on their medicines, right?
Yeah,
Yeah,
exactly.
exactly. Yeah,
Rather
exactly.
than do all
Yeah,
this sort of crazy
that's
stuff.
exactly.
So one thing that you've kind of been known for is looking at trends within markets and finding ways to sort of address those. And I think a lot of times when we're locked into managing a benefits plan, we miss that. Maybe would you mind sharing a little bit about how you see markets, how they're not stagnant, and the trends that you're
Mhm.
seeing within benefits?
Yeah, I think this is a big one for me is that when you I think for some reason there is, and it's particularly, and I will say this, that I've worked in, well before I worked in Walmart and was only doing healthcare. I came from management consulting, so had the opportunity to explore and engage in other industries. And so I think healthcare amongst industries in the U.S. Is the one that kind of at times struggles with this. Is that there's a tendency in the healthcare system in the U.S. healthcare system for those who participate in it, particularly benefits organizations, to believe that the market you're looking at is in some way static, um, that it isn't kind of that it's not that's not really moving. In reality, the market is one that is moving. It is evolving. It is actually evolving rapidly. It may not be changing, as quickly as some of us would like, but it actually is changing much faster than I think we entirely recognize. It's a little bit like being on one of those bullet trains in Japan that's going hundreds of miles an hour, and you may not
Right.
understand how quickly it's moving. The market's moving very, very quickly. But one of the things I think you asked a question about market, movement is, well, what is kind of what is then understanding, like, well, what does the movement in the market tell us about where it's going? So it's not, I don't,
Yeah.
like, I don't actually care about where it is today. I care about where does this movement tell me it's going to be? And I think that's one of the interesting things about the market today is that the market is, I think we are in the midst of a major transition in the kind of way the U.S. healthcare market is operating, that I don't think people entirely kind of get or understand. And that is,
Mm,
we have been blessed over the last certainly 5, 7, maybe 10 years with
right.
enormous innovation in the U.S. healthcare system. We're seeing
Mhm.
massive innovation in diagnostics and assessment and testing, which, as that continues to come forward, is going to redefine our ability to identify health issues sooner, earlier, at a lower cost, for a much broader population in a much more accessible way. You look at the rise of digital health solutions, the use of
Mhm.
AI to kind of enable us to transform how we do care delivery. You look at, I'll just say, even, build new care delivery model, virtual care models, telehealth,
Right.
care in the home. new different modalities using different types of health professionals. So, ones that aren't that don't have to be doctor based, but using APNs or community health workers or
That's right.
EMTs and different, like you're seeing an enormous amount of innovation occurring, and there's other categories of it. The fundamental fact though is, and this is one of the things I do call out about the movement of the market. The market is moving, it is transforming, it is evolving.
Okay.
That said, I think we're at a point where we can all agree that this innovation has both been a blessing, but it's also a curse. And the curse is it's
Yeah.
overwhelming. I mean, you know,
Yeah.
if you're trying to create a solution, if you're trying to identify, you're trying to implement behavioral health solutions for your employee base, good
That's
luck to
right.
you, because
Yeah.
I don't know how you pick from I'm being a little bit
20,
exaggerating,
30, 50.
thousands of it would feel like, but
Yeah.
it certainly is probably 30, 50, 100. And every day somebody else is sort of coming out of the woodwork. And you're like, well, maybe they're better than the group I'm working with. So I think
Yeah.
we've been blessed by the innovation, but we're also overwhelmed by all these point solutions. And so what I'm seeing right now is a movement, and we've seen this in other industries. We saw this actually in the internet move in the 90s into the 2000s,
Mhm.
with its development, that we're moving from the kind of rise of innovative point solutions to the rise of the integrators and the enablers. And what integrators do is they
Okay.
don't create new solutions. What they figure out how to do is take the existing point solutions, bring them together in more holistic, creative ways to create complete solutions. So I'm not looking for a virtual physical therapy solution. I'm looking for somebody who can bring me a complete end-to-end musculoskeletal, solution that helps me better manage my costs, lower
Yeah.
my costs, improve my trend, and actually produce a more productive workforce that has less
That's
pain.
right.
And so that's a very different. The enablers work very differently, because enablers are saying, I'm not trying to build a new point solution. I'm going to help those point solutions drive better consumer engagement, member engagement, and they can do it for multiple solutions. And so we're in that
Mhm.
transition. The only other comment that I'll make is, and this particularly goes to those to the individuals who are leaders of the benefit organizations. You can control and define that market. In other words, it's not you don't just get whatever comes from the whims of the market, meaning the market isn't just moving and you get whatever it creates. The more you put your voice out there, the more the market responds to that voice. And that evolution can be impacted and changed, sometimes sped up, sometimes slowed down, sometimes modified. And so I think one of the things I am kind of sharing a lot is, I believe that one of the things that if I were to give advice to those groups that are trying to lead a benefits organization or influence benefits organization, it's, we need this transition from the age of innovative point solutions to the age of the integrators and the enablers to happen faster.
That's a
and
great
and you need
concept.
and we need and so what you can do is, so you need to be out there calling for it. You need to be talking to your ASOs, and you need to be talking to your partners, like, where are my integrated solutions for, like, I don't just want I don't want another point solution. I don't need a
Mm.
digital, mental health solution for X. Like, if you need a full behavioral health solution, then say, what does that solution really look like? And define what
Yeah.
integration looks like, and push it and demand for it.
Love this. The age of innovation to the age of integration.
Yes. Yes.
What are the pros and cons of using the carriers to be our integrators?
Um, I think the pros are, in some ways that,
PBMs also. I know the
yeah,
PBMs are doing a lot of this right now as well.
I think the pros are, they already kind of sit in the middle of the market position. So I think they, um, arguably, are in a unique position to play that role. Um, I think the downside may be that some of be it the carrier ASOs or the PBMs or whoever it might be, they're in some instances, those are institutions that have legacy systems and legacy mindsets, as I'd call it. And so when you think
Mhm.
about the type of integrated solutions that are really the most valuable. It's not clear to me that all of them are fundamentally capable of doing the type of integration that you're going to want. It's that's sort of forward leaning. That's futuristic and future based. So I think that's
Right.
probably challenge one. I think the other challenge is I'm a little leery sometimes of those groups being the integrator, because in the course of their integrating, they attempt to drive, will they attempt to bias themselves um, around the solutions they favor? I mean, and like the example I give is in the pharmacy benefit space. I mean, let's just sort of call a spade a spade. I mean,
Yeah.
I
Yeah.
have I have a lot of respect for Express Scripts and OptumRx and Caremark. I think if you ask any employer, what they would also tell you is the biggest challenge that they're facing today in the pharmacy benefit side is probably tied to specialty pharmacy and management
No
of the
doubt.
specialty pharmacy trend. Yeah,
No
well,
doubt.
that's so you've asked those PBMs to be your integrators and bring you your complete pharmacy benefit solution. You shouldn't be surprised that some of those costs are out of control, because who are your three biggest specialty pharmacy chains? It's
Hmm.
the three largest specialty pharmacy providers in the U.S. are those three groups. So it's there is what I heard it characterized as, you've got the fox guarding the hen house on that one. And
That's
so
right.
I think fundamentally there's some risk in that as well. Is that, is there, if there are groups who are unencumbered by the legacy and who are not conflicted, you'd love to see that. You'd love to see that those groups kind of step into that integrator role.
Would you mind taking a minute and just unpacking that? I think a lot of listeners may not know just exactly how connected PBMs are to the selling of drugs, where, you know, you think, oh, well, Walgreens sold me the drug, right? And, you know, Abbott Labs made the drug, and then whatever, Optum or ESI or whomever, the PBM sort of, facilitates connecting me to the drug. But that's not always the case. They're involved at more places in the supply line.
Yeah, I mean, I think if you kind of divide the kind of two parts of pharmacy and pharmaceutical, I think about there being kind of the retail pharmacy, which are, this is like the drugs like Lipitor and Plavix and metformin for diabetes, and those drugs, which are
Right.
retail pharmacy drugs, right? I think in that space, the reality is, because of the whole mechanism for not just rebate management, but the management of the relationships with those manufacturers, and there's manufacturing fees and promotional. There's all these kind of dollars that sort of move. Yeah, I think on that side, one of the challenges has always been, to what extent does the formulary on the retail side that you often get brought to you by these groups fundamentally represent what I would consider to be the optimal formulary for your employees. Meaning, the optimal formulary represents the like perfect intersection between the clinical and the financial. And what I mean by that is, I'm trying
That's
to
right.
get you as an individual the very best therapy to address your underlying health issue at the very best cost, right? And so
Right.
what I will tell you is, and this is probably a year and a half old, but there was a group that I was doing some work with that is really kind of assessed this, and their view is that even today, that if you look at on the retail side of things, you look at drug utilization, their belief is that 40% of the drugs that were taken in the last at this point, this would have been in the last few years, were not optimal, meaning it didn't represent the very best product from a clinical and cost perspective. And
Mm.
so I think there's that challenge. I think on the specialty side, it's a very different deal. And here's, I
Oh, I'm
think,
surprised it's only 40% too. That seems really low to me, just in
well, I
terms
mean,
of
it
how
could be
many
more. I mean, this was,
options.
I think, in this one. And by the way, when I say this was optimized, where there was the belief was there was a better therapy clinically, where the
Mhm.
cost savings was, I think, the way they did the measure was more than $1 a month.
Okay.
So what they were looking, so that was, so of all prescriptions taken 40% of them, there was a potentially a better product clinically that you could have saved more than $1 a month on for the plan and for the member if you had sort of truly had a rationally and optimal formulary. Okay, so that's one side of the house. I think the other side of the house, and especially, is even tougher, because I think increasingly what we're seeing there is with these meds, it depends on what you characterize, especially, but these are products that cost $2,000, $3,000, $5,000 a month, maybe more.
Right.
Um,
That's right.
and what we're fundamentally seeing is that one of the challenges, one of the things that has been completely unmanaged, that in many ways you maybe don't care about on the traditional retail side, but you do care about on the specialty side. You care about efficacy, and efficacy meaning, does this product that I'm paying for actually work? Does it produce the benefits that we want? And on the specialty pharmacy side, the interesting thing is, if you look at the efficacy rates of the products that are out there, some of them are highly efficacious. They might be efficacious for 90% of the people who take them. Some
Like
are
a Hep C
moderately.
drug that cures Hep C, for instance.
Yeah. I mean, so that was a good example of the drugs that came out that cured Hep C. I think one of the early versions was efficacious 80% of the time. Well, that meant 20% of the time it wasn't. Okay, well, that's fine. But if that product costs you $80,000 for a 90-day supply, you sure care about the 20 or 30% of the time that it's not working.
Sure do.
Right.
Yeah.
And so the question is, what we have not put in place is any kind of efficacy management. So how do you assess efficacy? Well, it's around, you talk about personalized medicine. How are you using lab and testing and diagnostics or testing solutions to assess to predict whether a therapy will work before I start taking it? Or maybe I am taking it, but how do I assess as quickly as possible whether it's working, whether it's having any impact? This sort of idea, like maybe you don't care about that on the retail side because, I don't know, Torvastat and Lipitor, if it only costs you $9 a month, like, I don't care. Like,
Yeah, exactly. It's not
the
the diagnostic process would be much more expensive than the
right.
drug itself on trial and error.
But you use the example of, if you know that a hepatitis C med that's supposed to be curative is not curative a fifth of the time, I sure would like to know who's it going to work on and who's it not, or who is it working on not, because if it's not working,
right,
I should stop. Now, it doesn't mean that I don't look for other therapies. It just means, why would you throw good money at bad? And so I think the example,
and that's one of the best therapies we have. Like those drugs were extremely efficacious, and if we start looking at
wildly efficacious,
third or fourth round chemo and a lot of the anti-inflammatories that are just sort of out there, I think
the data has shown now after the fact.
80%.
Yeah, the data has shown after the fact that the investment in those drugs was ultimately beneficial because of the massive reduction in transplants and other things that you would have seen. So that was good. But what was more interesting is, we now know that, for a bunch of the people, it didn't do anything. So it was worth spending the money when we actually have the tools and the technology to know what will work, increasingly what will work and what won't. And so I think that's my challenge. And you say, well, why would the PBMs not go down that path? Well, if you're the group who's the dispensing entity, do you really want to reduce utilization?
Right. And now you want to sell to as many possible customers as you can, and you don't want to give away free product to those for whom it doesn't work.
That's right. And so I think that there are just kind of these challenges you see, and that those dynamics where I know we've picked on the pharmacy guys, but I think those challenges exist on the medical side. I mean, I think a good example, and one I know you know a lot about, is Walmart has, from a benefit perspective, this kind of this evolution in their thinking around medical provider networks, starting with centers of excellence, but where they've now kind of moved into the next version of that is this concept of high value provider networks that are predicated on really deep analytics and insights that are assessing individual providers and practices, not just the health systems, but down a step lower, and saying, is this provider delivering high value? And value meaning, are they delivering highly appropriate care? Meaning, are they not doing unnecessary procedures and things? Are they delivering what is appropriate? Are they delivering high quality care? Well, you could say, well, that should be great for an ASO to want to promote high value networks. But what I'll tell you, in some instances, what we've seen is it actually runs counter to the ability to go out and say that we have more. If you create high value networks, it may mean that you're actually thinking that some providers shouldn't be in your network because they deliver really low value. Well,
Yeah.
but you now maybe can't go out and say that you have the biggest network in the market, that you have the most providers or groups under
Yeah.
contract, right? And
Yeah. Well, don't the
so there are
carriers
these
do that though?
conflicts. Say again?
I mean, that's what I'm paying Blue Cross or UHC, Aetna, Cigna. I'm paying them to make sure that only, quality services are being provided to my patients, aren't
Um, I think you are. I think
I?
what I would say
They
is,
say that.
yeah,
They say that,
what I
right?
think often is being paid for, and that what I see people is that you're being paid for on two things: size of the network and
Right.
the network rates. Meaning, do I have the biggest network at the lowest cost? What I will increasingly tell you is unit cost is irrelevant to your total cost. What's more important, if you have
Mm,
a whole big network, but where most of those providers, and I'm making an assumption here, but if most of the
you're
providers
okay.
are low value, such that they're delivering highly inappropriate care at a poor quality, your total cost is going to be way higher than somebody else who has a high value network, but their negotiated unit rates with that high value network aren't as good, right? So what I
Mhm.
would say is, I think to your question, isn't that what you're buying? I think what you're buying is you're buying access to. Often you're paying for a very large network and trying to get the very best rates. I don't
On unit cost, best
Yeah,
unit
on
cost
unit
for as
cost,
many
as
people as you
opposed
can.
to saying, "Am I buying something that is giving me the highest value?" And
Yeah.
that's a new kind of reality that I think as employers, particularly, um, you're going to have. That's an area where I do think uh, th- that you can't just hope that your ASO brings that to you. You're going to have to demand that. And by the way, here's why you. What I will say to everybody, who's listening and hoping they stayed on, is the if there's two benefits there. High
Mhm.
value networks result in better care and ultimately better health for your employees and your plan members, because if they're not getting inappropriate things done, if they're getting higher total quality, they're going to have their health will be better for it.
Right.
Like example, if somebody who got a knee replacement didn't need a knee replacement, the person who gets a knee
Right.
replacement that didn't need it, their health is poorer for that. It's not better for that. But the
Right.
other thing is, in an
There's a
environment,
cost to
and
that.
yeah, it's the cost reduction. And what I'm going to tell you is, I don't think enough people are talking about it. The numbers I'm hearing about the potential cost increases that employers are going to bear in the next year to 2 years to 3 years. In aggregate, I'm hearing health systems say that because of inflation and other challenges, they need to see their reimbursement rates go up. They believe their costs have gone up 8 to 9%, so they're asking for 11 to 12% increases. When you start to kind of play that out systemically, you might be seeing costs for the employer double digit increases year over year for a while. And
Wow.
I don't know an employer today. I mean, I don't know how you go to your CEO or CFO and say, "Hey, bad news. The industry's like in a bad spot,
Yeah.
so we're going to just have to take up our benefits costs, you know, 15% or 12% or 10% or even 8%. Egregious." I
Wow.
think that's why I think we're entering this phase that if we're going to have to find really aggressive and creative ways to fundamentally impact that cost reality and cost
We
trend.
got to decrease that utilization. That's right. We need increases in low cost preventive utilization so that we
Yep,
can avoid the high dollar stuff, and then we need to steer it only to the
100%,
most appropriate
100%,
providers.
100%.
How Obviously, misaligned incentives kind of exist everywhere. What are some things that employers can do to try and realign the incentives for their employees at the consumer level, and then also, if possible, with any of their vendors? And it may not be possible.
I think that's it's a great question. I think one of the things I find is one of the greatest kind of points of misalignment is um, it I am not a believer that the market is an entirely rational market where you fundamentally change how people get reimbursed and it magically changes the care delivery
Mm,
system. So
hmm.
I'm not suggesting that there isn't a role for changing reimbursement, but I don't think it feels like a lot of people talk about it as if it's the silver bullet, and I just don't think it is, and
That's right.
it's not proving it. That said, on the flip of that, on the other side of that, one of the areas of misalignment that I see is from a consumer perspective, um, the the massive money does matter, right? And small
Hmm.
changes matter. I mean, like going back to the $4 generic program. What was
Right.
interesting about the $4 generic program when it launched is that for if you looked at tier one generic copays at the time that the $4 generic program launched, most of those tier one programs had generic copays that averaged between $5 and $10. So you're like,
Right.
okay, what's the big whip? Like people are talking about $1 to maybe $6 and save if they've got a pharmacy benefit, $1 to $6 in savings. But what I
Yeah.
can tell you is that very small that dollar change. There was a study that was done, I think, maybe about 6 to 8 years afterwards, that said that was the single greatest driver in the decade that followed. The launch of that program, the competitive response market, was the single biggest driver of medication adherence improvement that had ever been seen.
Oh my
Right. And
gosh.
so my point is, I think on the consumer side, one of the points of misalignment is around how plan design is done. That you think about if your point earlier, I want to encourage you to do the preventative stuff. I want to encourage you to go um, get an annual health screening. And if you're a guy who's 45, I want you to get that colorectal cancer assessment. I want to, if you're pregnant, if you're a mom who's a woman who's now pregnant for the first time, I want to support you in having access to, maybe being able to talk to a nurse midwife or a doula, every day if you want. Like, I
Mm.
want you to be able to do those things, but if I've sort of designed things in such a way that I'm making you pay for it because you're sitting under a high deductible, or that there's this that I often sort of see this misalignment. Like, I want you to do these things, but I've actually made the things that I really want you to do um,
Mhm.
uh, strangely punitive or financially difficult. Where the
Right.
irony is, procedures become much easier. So if I'm on a $3,000 deductible, I'm told this procedure I'm going to get is $10,000. Like, at some point, the fact that the plan's covering so much of a portion of that, it actually mutes the underlying true expense of that. It's what we saw going back to drugs. Um, there was a point in time when we looked at generics, and the underlying cost of an average generic at one point, this was about $13. The average underlying cost of the brands was about $280. But if you looked at the price differential that consumers were often paying a $7 copay on generics and a $45 copay on brands. And so you say, well, that's still a big difference. Like, yeah, but we were talking, there was more than $250 of difference between the brand and the generic, but you actually made that far less. You made that less than $40. And so then you shouldn't be surprised that your brand utilization is higher than it, because the consumers only know what they see and only know what they pay. So I think one of the biggest points of misalignment is, what is it that what are the actions you want to see your members actually take? And then go back on the design and say, well, what have you done from a design? Are you doing anything from a design perspective that might actually be discouraging them to not do that, or might be encouraging them to do the opposite of that. And I think that's where um, I think that's one of the big areas that I've kind of seen. And you know, thinking through, like, what are the all the actions you want to see people do or not do, and then how do you kind of work back to new plan designs that drive that,
Yes.
motivate that action.
I love that. Call the, I don't know, the sort of the action design model of benefits, where we start with what are all the highest leverage, most important actions that we want people to take, maybe in a descending order, and then say, okay, what in our benefits design encourages this, and do we have the data and tools necessary to facilitate the action, right? Because
That's
if we
right.
say, oh, we
That's
want
right.
people to go to a center of excellence, but we don't have a center of excellence, like,
Yeah.
okay,
Well, and I'll give you
or are we
one
helping to
that's,
navigate them? What are the tools that they need?
yeah, and I'll give you one that's not necessarily financial in nature, but in one of the conversations I've had with a number of employers is, I think, increasingly this sort of desire to say, I want every one of my plan members, every one of my employees to, if they could have reasonable and ready access and consistent access to primary care. So let's just say that was your
Hmm.
goal. Um, the so you could say, well, look, we've put in place an HRA, so we will provide first dollar coverage, for somebody to go, have, that they can use. It can be used in primary care. It can be used for their annual
Hmm.
screenings and those kind of things. Okay, and that's all well and good. But maybe the reality is, your members are in a community, and this isn't uncommon, where I've seen this in a ton of communities across the U.S. where primary care access is very limited. Even if it does exist, maybe some of them have closed panels. They're not taking on new patients. Or if you call them, they will take on new patients. Or even if you have a primary care physician, it's sort of like, experience that I had not too long ago, where I was scheduling my own physical, and there were some things that I actually was eager to get done pretty quickly. And I was scheduling it in March, and the best I could get was an August date. Right. So you think
Wow.
about
Wow.
the kind of fundamental reality, and that's not all that uncommon, right? So,
Right.
um, so you start to think about, okay, well, you're encouraging, you've built a plan design financially that does reduce some friction in primary care, but it doesn't matter that you've made it cheaper if I can't even get an appointment in a reasonable period of time, or nobody, or I have to
Sure.
travel 30 minutes or 40 minutes. So, you start to say, this is where I started to see a couple groups where there was one who said, I'm actually truly committed. So I want to work, this kind of movement to using some of the virtual primary care providers, groups like Health Tap or Babylon or K Health or Galileo
Sure.
or whoever. The reason I'm going to work with them is not because I'm just trying to double down on virtual care. It's because I actually want to, because they're committed to me a model that says, the member, I can bring them, they will connect them with a primary care physician and a virtual practice that will be theirs and be responsive. And
Mm.
I want to couple that with some sort of ability to reach the end of that member in their home. So if they need a lab test run or an immunization or something, I'm not going to I'm going to come to them to the same way that Instacart or, delivers your groceries today, or I'm going to come to
Right.
you and do these things that you need in your home. And I'm going to reduce all the friction points that are associated with people being able to access primary care. I'm going to make it super accessible, super convenient. I'm going to make it super affordable. I'm going to do all these things. I think that, what I'm seeing there is that's the perfect example of alignment, where it goes back to the consumer centered design approach, which says,
Right.
do you fundamentally understand what is the action you want to see? Do you understand why people aren't performing that action today? And then how do you,
Mm.
as a plan, create design, not just the plan design itself, but how do you design a solution that fundamentally reduces the friction points and improves the ability of your members to engage? And I think that's where, when you talk about misalignment, that's where I think sometimes a
Mm.
lot of plans don't go far enough.
How did you, I mean, you engaged with with customers all the time, both in in a business setting, but also in health and benefits setting. What are some of the aha moments and discoveries that you had that were like surprising?
Well, oh shoot, there were a bunch. I mean, I think one of the ones, one of the biggest is that, um, and this goes back to kind of my learnings on the consumer centered design approach. That I think what I saw is a lot of solutions where, as I sort of deconstructed them, at the end of the day, the perception of the consumer or the individual, of the customer that they were ultimately serving, was not one in which that customer, that individual, was held in high regard. And what I mean by that is
Mm,
where ultimately like these programs were really designed in a way where the natural assumption was that the member, or the person, the consumer you're serving, was either lazy or kind of stupid, or not interested in engaging. Um, what I actually found was something that was very different, right? Which was
mm,
a way more, and I'm speaking to Americans here, that Americans, when it comes to health, it is a top concern. They're deeply stressed, and there's a ton of stress that the typical American feels about their healthcare and their health and the healthcare system and the health of their family. Um, that they are actually surprisingly, put in a lot of effort to be informed. They are not lazy. They will
mm,
work hard, but that often, the solutions just missed completely how we as people operate. And
mm.
I'll give you an example of one. This was one,
Yeah.
that a program that Walmart had, that I still to this day am astounded by. And it was developed by the kind of wellness team on the benefits organization. The program is called ZP, or it stands for zero
Okay.
pressure. And the original kind of iteration of it, what the I'll give you the punchline. The punchline was,
Yeah.
um, within a few years of them running this program, there were more people on Walmart's plan, associate plan, that lost 100 pounds and kept it off than all the other weight management programs that had ever been available to Walmart associates combined, ever. Like, not even close. Like, massively more people. And you're like, okay, great. Well, this must have been a spectacular weight management program. Well, I'm going to tell
Right.
you, ZP had nothing to do with weight management, zero to do with weight management. What it was is, it was sort of built as a wellness concept, and what it really was intended to do was to get people talking about the things that they are doing to live a better life. So it was really it was almost a kind of wellness social media platform where, it did two things. It encouraged people to tell their stories, and if you the idea would be, if you told your story, if your peers thought the story was really great, you could potentially win a $100 prize or a $500 prize. I think there was a grand prize of like 5,000 or 10,000. But ultimately, what we found in that program, what was really interesting, is the prizes didn't really, they were important, but they didn't really define why people contributed so many stories. Like, I mean, there were literally hundreds of thousands of stories coming in. And a lot of them were health related. Some of them were around financial well being and other things. And I'll give you the example. There are two famous stories that it's just kind of fun stories that people always love to hear. But the question was, well, why was this thing so effective at helping people lose weight? Well, it was
Yeah.
predicated on the original group who designed it. It was predicated on two really keen consumer insights, and behaviors. I mean, understanding us as behaviors. One is
Okay.
that when we do something we're proud of, we love to tell others about it. It explains why Facebook is still worth, hundreds of billions of dollars. In other
Sure.
words, like we talk about, everybody on Facebook. If you look at most of the posts, people are like living their best life. They have really smart
Sure.
kids, and they're doing great. That are doing great in sports and school, and then everybody takes the best
Yeah.
vacations and has the most fun. It never shows you the disasters that are our houses, right?
Right.
So we love to tell others about the things that we're proud of. The other thing is we're
Right.
all voyeurs, right? We love to like peek in our neighbor's window and understand like what are they eating for dinner and what are they watching on TV. Like we're
Sure.
just kind of interested to know what our peers are doing. And so that was what
Right.
ZP realized. People want to tell those stories and people want to read those stories and engage with those stories because they're interested in like, hey man, you lost a lot of weight. Like, what did you do? And like
Right.
some of the two stories that kind of ended up being famous out of it was there was a woman who um, knew that she needed to lose some weight and a lot of weight, I guess, and she was eating a bag of chips a day, and everybody tell her you need to cut out the chips, but she really loved these chips. They made her happy. So what she started
Right.
doing was she started instead of eating the chips, she licked them, and so every day she would like lick on chips. So she was the lick a chip person. And people read that story, and at first you laugh and you're like, but is there something? So you started to hear stories about people who would lick candy bars or lick, that
Yeah.
they and you're like, hey, I'm sure there's no weight management program or no doctor who's like lick a chip because there's a ton of sodium in it. Like never, but
Yeah,
this
exactly.
woman
No, nobody's
lost.
gonna suggest
Yeah,
that.
the people who did the lick a chip, who did what she did, lost hundreds of pounds of weight. Like and and you'd hear stories like that. You hear stories about like the mailbox guy who he came out and he knew he needed exercise and he went out one day and he could only make it. He lived in kind of a more rural community. He could only make it to the mailbox of his neighbor before he got winded. Came back and he was embarrassed, and his wife apparently told him, "Hey, don't get embarrassed. That's good. You made it to one mailbox a day. Tomorrow, see if you can make it to the second mailbox, and then the next day you'll see if you can make it to the third. Like your goal is to make it to one more mailbox every day." And so he did that again, and the rest was history. Lost a bunch of weight, was able to walk down the aisle of his daughter's wedding and not be winded.
Wow.
My point on that story is increasingly it's what it told me was, and this was great learning, that we're not designing solutions that are actually fundamentally based on how we think and operate and engage as humans, as people. That
Right.
we're building them again, and that if when we do, guess what happens? Massive engagement. Like that these programs that are really fundamentally understand how we as consumers engage and behave and what motivates us and what demotivates us. That when that kind of
Huge.
behavioral kind of understanding is applied in a significant way, you will see people engage. That it's not that people are not stupid or lazy. They want to engage. Often there are frictions or challenges, right? I
Okay.
think you may know Alex Drain, who's a very successful healthcare entrepreneur, founded a
Mhm.
company called Eliza Corp. That was one of the early health engagement companies.
Right.
She did this work called the unmentionables, and it was really interesting. I mean, what they found in that was that most people who are diabetic know exactly what they need to do to manage their diabetes. And if you have somebody who's diabetic who's not managing their diabetes, it's probably not because they're stupid. It's also probably not because they're lazy. What she found is because there was usually some unmentionable that was causing strife in that individual's life that was getting in the way, that they were caring for an aging parent or they were dealing with stress issues in their own relationship with their spouse or partner. um, they hated their boss and so their work life was sort
Mhm.
of overwhelming them, that their sex life was troubling or problematic. Like it was always kind of funny, but like
Sure.
what you now realize is these weren't people who didn't know how to manage their
Mhm.
health. It was that something else was in the way, or that the solutions
Right.
that were out there didn't fundamentally understand the dynamics of the life I live. And so I think that's the big learning is that
Huh.
how do we too often when we go into these design we put on our hat as the head of benefits or the head of the ASO or the physician in this practice or the head of this health system. Like, no, at the end of the day, you're still just an individual consumer. Like, you know, how would you want something served up to you to get you to do what to do something? And I think that's where we kind of often miss.
Yeah. Which hat are you wearing? Are you a benefits manager or a human, just a
Right.
person trying to think through this? What are some other design kind of principles that we can include that you found that would generate big changes in behavior or activity? if you have
Well,
others.
I think one of this is probably, I don't know if it's a design change. I think one of the biggest, and this is something that still surprises me, and you would, and maybe you'll tell me this isn't as big of a problem, but I'm surprised at how often it comes up in conversations, which is the very best industries, the very best sectors, the ones that have performed the best, have tended to be those that it's not just that they have massive access to data; it's that they use their data and do very robust advanced analytics to generate compelling insights to drive them. And
Mhm.
what I'm one of the things I'm kind of surprised by, and this is a bit more fundamental, is how often I hear sort of employers say, "Well, I actually don't have access to that data, or I don't have access to my full kind of data set," or
Mm,
if they do have access to their data, like, what are you doing with it? Like,
right.
what kind of insights, deep analytics process? Well, I just farm that to my benefits consultant. That's what
Sure.
I get, whatever Mercer
My
or Willis
consultant does that.
Towers or gives me, or
Yeah.
or whatever my ASO gives me. Like, yeah, but like I'm not, and by the way, that's good. I'd encourage you to get the insights from them, but you need to
Sure.
be working with other groups as well. So one of the things I think is a fundamental problem as an industry, and particularly with employers, that they're just not using the full breadth of the data that they have available to them, and then going out and seeking out the advanced type of analytics they need to generate the insights that could compel them to really more progressive approaches. And like and look, I understand there's all kinds of constraints, there's regulatory issues and whatever, but I mean,
Yeah.
it's like a good example is to name me how many employers in America, big employers in America, have a data system that integrates their healthcare spending with their workplace productivity data, or even go as far as I had this one recently, like, that has linked up what you're doing on the workers' comp and disability side, and that data with, like, like, is there
100%.
something that, like, all this data, um, because the very best industries are increasingly the best companies, I believe, are the ones who are figuring out how to massively unlock the data that they have available to them. It's not about going out and getting more data. It's actually about unlocking the
Right.
data that you should have available to you to create insights to enable you to operate more effectively. And I actually think,
Mm.
from what I've seen. Now, you again, you maybe tell me different, but a lot of the
No, no,
employees,
no, no, no.
I think we're not even in the first inning, like, we're of what should be possible, and that is a big
Totally
one.
agree.
That's a design approach, which is, it's hard to design anything without really intelligent insights driving your design. And so the only way to get there is you got to invest in the data and the analytics. And by the way, here's my view on that.
Hmm.
That should be a relatively easy sell to your, like, CFO and your CEO, because
Right.
if you got a good if your company, I don't care who it is, I don't care if you're a tire manufacturer, a cable company, a discount retailer, if you sell fast food. At the end of the day, I'm going to argue that every one of your businesses is not that business. You're in the data and the analytics and the insights business, and you are only as good as the data you have and your ability to leverage that data to create insights to drive and compel your business. And I think,
Awesome.
and so that's the other piece, is that I just, if I could wave a magic wand, I would give every employer access to all their data. I'd help them figure out how to have all the data they have about their employees be integrated in a compliant way. But then I would stick on top of it great analytics, and I would have a team who's, like, their job is to generate insights to drive the strategy. And I think that's something I think that's lacking.
Everyone, now just a quick word from today's sponsor.
Hello.
Hi, I'm here to pick up a prescription,
Okay. Okay, your total is $80.
but I have insurance.
We ran your insurance. That's just your copay.
hold on to that for me? I'll be back later.
58 million American adults can't afford their prescriptions. Many of these people work for companies just like yours. Start giving your employees 100% medical coverage with Catalyze Health.
What are some of the most common mistakes that employers and benefits teams are making that that are relatively easy to correct for?
Um, that's a good one. I mean, I think probably the first one that I don't know if it. I think maybe in my mind, the thing that comes to that I think of there first is
Mm,
that I actually think that make the kind of problems more complex than they are. Um,
mhm.
and the belief that, as you think about what I've got, I've got to solve for these 10 things or 20 things. I'm like, no, no, no. Like maybe you're just better off solve. What's the one thing that matters that if you could just do this and do it well and get it right, it would have and focus there. And like the example being going back to the network side of things is that I've oh well doing the centers of excellence work or trying to
Mm.
you know creating doing this moving down this path of high value networks. Wow, that just takes a lot of time and I don't have that time. And I'm like, well, why do you not have time? I mean, these are things that
Right.
could massively improve productivity of your workforce and could reduce your costs by 10, 20, 30%. Like that seems like they're a big deal. Well, I've got to put in a fertility benefit and I've got to do this and I got to do that. So I think at some point they, the biggest kind of criticism is I do, I do, I just think sometimes it's, you got to focus on the things that matter. And sometimes we let ourselves kind of create complexity where simplicity. We allow ourselves to kind of get overwhelmed when we could kind of simplify it. So I think that's probably one of the biggest challenges. I'm sort of seeing. Um, um, the other one is it may seem like it's going to run counter to that, but
Hmm.
the other mistake I think
Mhm.
is that, and it goes back to the old cliche of like no one gets fired for hiring IBM.
That's right.
That I think increasingly, and there is value in thinking about how to deconstruct a benefit. So this may sort of run counter to what I just said, but I don't think it does.
No, no,
And
no.
I'll give
This is
you an
good. Keep going.
example of like the pharmacy benefit space. So it's like,
Mm.
no one gets, in the same way, no one gets fired for hiring IBM, no one gets fired for hiring ESI or Optum or Caremark. And
That's
I'm
right.
not saying
It's
that
your
you
mark.
shouldn't
That's
hire
right.
them, but I'm sort of struck by increasingly that if you deconstruct what a pharmacy
Mm.
benefit manager does for you, formulary management, and they bring you your retail network, and they bring you, mail order, and they bring you maybe the administrative
Mm.
function, the adjudication, the specialty side, and then there's more. I'm kind of overly simplifying it, but
Right.
one of the things I'm actually seeing is
Mm.
increasingly, if you were to actually, in some cases, for some groups, if you were to deconstruct that into its component parts and go out
Mhm.
and find the best in class solution for formulary design and management or mail order or specialty management, and that, and then figure out how to kind of bring it back together, the
Mhm.
fundamental result is you actually have something that could represent
Mm.
far better results, better, much more cost savings, than
Right.
you would ever get from what you would think of as sort of
Mm.
scale players. I think some groups are just saying like that just seems like a lot of work, but this is one of those instances where I
Mm.
think the work has benefits, and so I think
Mm.
at times people are kind of not willing to deconstruct certain things because they think it generates too much work. But I think in the end, if a little bit of work will actually generate huge returns in the long run, and I think that's a mistake that a lot of people don't at least consider. I know in some instances it may not make sense, but at least consider it, at least kind of think about it, at least explore those options.
Right. Because, you know, because a program might take 2 or 3 years to put in place, we
Right.
end up going a decade doing 6-month at a time programs that get nowhere, rather than doing something that takes 2 to 3 years that would be a fundamental transformation.
100%.
That is rampant. Many people don't understand that being a huge company makes it really hard sometimes. It can be a disadvantage for trying something quickly or running an experiment. How do
Hmm.
big companies run small tests?
Well, some of them don't, and I think it's a failure point. I think the
Yeah,
best
I
big
agree.
companies, the best big companies, and I'll use I can use the sort of example of Walmart and the retail side. Um,
Mhm.
Walmart constantly had, I mean, it had hundreds of tests going. And one of the
Mm,
messages you heard that I can remember, there was an individual who was CEO of Walmart's U.S. business, Greg Ferran, who made this comment in a meeting where somebody was sort of commenting on like these tests, and he said, "Look, here's the way you should think about it. If as big as we are, if we go in and do 100 tests in 100 different stores, even if they all are unmitigated disasters and they cause each of those stores to crumble, even if it like if this was like the end of days, like you run these tests and they are such a disaster that this we had to like shut the store. I don't know why. Like there's absolutely no scenario that ever occurred. But even if you played
can't
that,
even think of an example that
if you
could do
even
that
if that were
badly,
to the
right?
case, he goes, guess what? I've still got 4,900 other stores. In other words, the scale of the business is a luxury that testing in it, you're not going to implode. You're not going to ultimately kind of impact the financials in any way. But without that testing, you can't fundamentally transform the business. You can't change
Wow.
the revenue basis for it. You can't grow the business. You can't make it uh, work better for consumers or be more profitable. And so I think my sense is that is that you've got to take that mentality that testing there has very little downside. Um, it's not going to cripple you, and an enormous
Right.
upside. So why don't you do more of it?
Mm,
And people say, well, I can only handle so many tests. I don't like. Well, then there are ways to kind of create testing platforms that I think enable you to do more. And I think on the
right.
benefit side, that I'm not even going to. This isn't even a Walmart example. This was an example of a manufacturer who who I've interacted with, who I think did a reasonably good job of testing. And what they had
Yeah.
are these kind of small little plants all over the place, and so or they and excuse me, they also had logistics centers in place, and they're like, I'm going to test this in logistics center 10. And if the worst thing that happens is I like cause that logistics center to implode, or everybody there hates my guts because I implemented this program and wanted to kind of test it out, then great. Like we'll go and figure out how to correct for it. But it's not going to bring down the whole benefit plan and the system. And we'll. So I think you've got to understand, without testing, I don't know how you fundamentally learn.
Yeah.
And going back to the Greg Ferran comment, he had this quote that I use a lot, which is, you get 1 point for talking about it and 9 points for doing it. And it was a commentary in my mind about learning that said, those of you who think you can just sit in a room and whiteboard your way into a strategy that works, you're wrong. You actually have to apply that, and you have to see what comes of it. And that has 9 times the value that comes from the talking, right? And
Yeah. I
so,
love that.
yeah, and by the way, the one thing, my own personal experience in this is, strangely enough, when you go and kind of create that kind of micro testing environment, and you're
Mhm.
transparent with the people that you're testing on, that we're testing this, and they're actually super excited because I think they got chosen. They're like, I must be special. I must be in a special location because you wouldn't have come tested here unless you cared, you thought we were doing well, and you thought we could handle this test, and you were interested in my perspective. And so the irony was, I actually know of a handful of groups who've done testing, where the like net promoter scores, or like the engagement, the employee engagement scores were higher in those locations that testing was occurring than those that didn't, because the people who are getting tested on them are like, you know what, I feel more connected to the business because you're allowing me to be part of this process. And so I wouldn't lose sight of that.
That's an awesome insight. How do we Here's a question that I have for you that I think you uniquely can answer to anybody I've interviewed. If if we could wave a magic wand and we become successful and we're now able to steer our people truly into value, low cost hospitals that offer great quality, the crummy, high cost, entitled, sort of bad actor hospitals will all start to have, fewer and fewer patients, right? They'll start drying up.
Mhm.
And in theory, one of two things happens. Either they change and they respond to the incentives and they start lowering their prices and enhancing their quality in order to attract business back, or they go into solvency, the leadership gets tossed, and maybe they sell for pennies on the dollar to somebody who can manage the hospital. How do you see that playing out? I mean, that'd be the best possible outcome I think we could have, is that the market starts to respond. But I
Yeah.
worry, or would we just bankrupt a bunch of hospitals and then the good ones buy up all their competition? Do we accidentally create some unexpected bad consequences there? Or do we, is that an unkind thing to want to have happen to these worse hospitals?
Yeah, ultimately, I actually don't know that I think that sort of scenario is the one that plays out. What I actually think is happening is, today, again, when we go back to this concept of high value is about, am I as a provider delivering the most appropriate care, highest total, highest quality, where ultimately the result is I get the kind of, I'm able to generate kind of low total cost. And it's,
Yeah.
I think, there some of the early indicating data would tell us that, well, what makes one provider deliver higher value over the other. The only sort of correlated um, thing that anybody can find is, it ties back to where you did your residency. So it's like, how well were you trained, which is probably not surprising.
Really?
But I'm sort of mindful, and there was a study done by Johns Hopkins that showed, when individual physicians and practices were given visibility to their performance, real visibility to their performance, that showed them, here's what high value looks like, here's where you're performing, here's where some of your peers are performing, um, and here's the delta between you and the highest performing. What that Johns Hopkins study that I remember, and this goes back a few years ago, showed was that almost that physicians' ability to transform their practices is rapid. That you saw is the vast majority of the physician or the providers and the professionals would change how they practice, because they'd look at it and they'd say it was very much data driven. I can see for the first time what good looks like. Like, I know where, here's good. I know where I'm at. I know where my peers are at. I don't want to be the guy who's ranked 9th out of 10. I want to be the guy who's ranked 1st out of 10. Like, I
Right.
want to be so I think with it, so I actually have greater hope. I think part of what's got to occur is that, and this is why I don't actually fault necessarily the individual providers on this. I think we have done a disservice systemically, that we actually don't give them the not that just the data. I don't want to give them the raw data, because I don't know. Like, how do I give them the
May not be
analyzed
me.
information, the analytics, and the insights that let them know how they're doing, let them know what good looks like, and say, and then create some accountability. It says, really, like, this is what good looks like. How do we, what's got to happen to get you to the good? And so what I actually have hope for is that, if we could build that kind of transparent assessment capability across the entire country, that we would see massive improvement. Now, the problem becomes, and I'm mindful of it, and you were talking about hospital economics and health system economics, that if we do that and did it, if we could just flip a switch and gave everybody full transparency and great insights and analytics, and if in the next 3 to 4 months, every provider changed her or his practice to sort of practice at the optimal level, we would see a massive decrease in C-sections and reduction in NICU utilization. We'd see a massive reduction in hip and knee replacements and spinal fusions and knee scopes and stent placements. And we'd see a bunch of a reduction in unnecessary images, people not getting ultrasounds that don't need them.
Yeah.
Well, guess
Arthroscopies
what? All
would
those
dry up.
So
Everything.
all those things generate revenue, and in many cases generate reasonable profitability. So I am kind of mindful. There's part of me like, what would happen if some of that, my view is that there'd be a little bit of pain. The providers would do well in it, but that ultimately would do well, but there would be you would have a transition. Like you would have to,
That's
so
right.
I'm less worried about the kind of health systems swallowing up health systems. What I'm more worried about is, what does it take for us to give that level of transparency into clinical performance to health professionals across America?
That's right.
I think about, if you're a professional baseball player today, the amount of analytics and insights coming in that inform the assessment. You think about Moneyball and everything else and how they're assessing your performance. I would like to do just 1/100th of that for our health professionals.
Oh, wow. Moneyball for our physicians. What a cool concept of just
Yeah, I mean, maybe I don't want to,
1%
of that kind of insight. Yeah, exactly.
I love that so much. This has been an absolute treat of information, strategy, thoughts, and visibility. Thank you so much for joining us. Thank you for the listeners for listening in. Marcus, if people wanted to reach out to you, learn a little bit more about what you're doing now, or had other questions or other thoughts that they wanted to bounce past you, what would be a way that people could reach out and find you?
Honestly, the easiest way to reach me, I'm now I'm easy to find on LinkedIn, and just send me a message and I'll send you that's the easiest way, sending my email or however you want to contact. But just ping me on LinkedIn, and love to anybody who wants to chat. That's one of the great benefits of being semi-retired at the moment, that I get to have a lot of time to have lots of fun conversations.
No, this has been wonderful. Thank you so much for joining the show, and
Thank
thank you for listening to Broken Benefits. Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible. Until next time.